Hello, everybody. Welcome to my YouTube channel, Expert Urologic Pathology, where I bring simple to follow insightful approaches to the diagnosis of urological tumors, some of the hot topics of the field, as well as new emerging science. Today, I have a very important guest, Dr. Priti Lal, who will be sharing with us her experience on how to handle inverted or endophytic urothelial lesions, which is diagnostically often challenging spectrum. Priti is an associate professor of pathology and director of GU Pathology Service at University of Pennsylvania. She is an accomplished pathologist with vast experience in the field. So without any further ado, welcome Priti. Thank you for your contribution.
Thank you, Dr. Shah, for your invite to come and speak in this great series. My topic today is inverted urothelial lesions or endophytic urothelial lesions. And in this lecture, my aim is to develop some foundational knowledge of the papillary lesions. So I will describe the WHO classification of papillary lesion in short. Then we will go into the details of inverted urothelial papilloma, and this will set the foundation for us to understand the differences between inverted growth of indolent entities as well as malignant and overtly aggressive entities in the urothelium. We'll also describe benign and malignant entities that involve the lamina propria and may mimic inverted growth pattern. In the end, we will summarize both the benign and malignant mimics of these entities. So here we go. The WHO recognizes 4 distinct entities as far as the papillary lesions go: the papilloma, papillary urothelial neoplasia of low malignant potential, low-grade papillary urothelial carcinoma, and high-grade papillary urothelial carcinoma. Papilloma are simple exophytic lesions with simple papillae without fusion. The urothelial lining is normal, and the umbrella cell layer can be very prominent. Panlum again have very simple papillae. They're exophytic growth pattern, which is lined by hyperplastic looking urothelium with mild to very slight atypia. A low-grade papillary urothelial carcinoma have obvious nuclear atypia with fusion of papillae, and high-grade papillary urothelial carcinoma have pleomorphic nuclei, high-grade looking nuclei, and the easiest to really diagnose. A papilloma has a very well-oriented lining. You can easily see the basal layer with the intermediate cell layer and the umbrella cell layer, as shown here. And these are usually a solitary exophytic neoplasms, and the lining will remind you of normal urothelium. So if you take a quick look at adjacent urothelium, the lining of these simple papillae will be very similar. Whereas in a papillary urothelial neoplasia, which also tend to be usually solitary lesions and usually exophytic, they have a hyperplastic lining as shown here. And there's just a diffuse increase in the number of nuclei, but the nuclei still tend to orient perpendicular to the basement membrane and have a slight roundness to them compared to normal urothelium. So this picture I put in here to remind you that the umbrella cell layer of papilloma can be very, very prominent. And as you know, umbrella cells can have a very basophilic nuclei. They can have very pleomorphic or atypical looking nuclei. They can have binucleation, etc. And these features are a little bit disconcerting, but eventually, if you recognize them as such, they become easy to really recognize as benign and benign nuclei. So just keep these in mind as we go through the differential diagnosis in the subsequent slides. Similarly, in the papillary urothelial neoplasia of low malignant potential, you will see some nuclear atypia, but what you will find is a degree of regimentation and order. So that is something that you should keep in mind. And so the morphologic criteria that we use for the WHOI subsystem for the exophytic papillary lesion can be directly extrapolated to the endophytic inverted papillary lesions. So if a exophytic papilloma has normal looking urothelial lining, similarly inverted papilloma will have a well regimented normal looking urothelial lining. Punlump has a hyperplastic looking lining, and inverted punlump will similarly have a hyperplastic looking lining with some degree of regimentation. So and so on and so forth. So this is something that you should keep in mind. With this, we go into the clinical presentation of inverted urothelial papilloma. Now, the majority of the patients present with painless gross hematuria, about 60%. A subset will present with microscopic hematuria, which will be picked up as a result of some other workup for urine workup. A small percentage will present with dysuria, and rarely, if the papilloma gets infected, the patients may present with pyuria, abdominal discomfort, and acute urinary retention. These are really rare entities, and they constitute just about 1 to 2% of urothelial neoplasia, and they can be seen in any age group, as young as 20 years old to older individuals. There is a distinct predilection for men, with a male is to female ratio of 7:1. Interestingly, majority of these lesions are located at the bladder neck, but they can be seen anywhere else in the urinary tract. Majority of them are unifocal, but a subset can be multifocal. As I go through these slides, I will keep showing you some histologic features for each slide. So the name inverted urothelial papilloma says all the features that you are supposed to look for in its name. First of all, inverted. So you have to make sure that you understand that this is inverted growth into the lamina propria, not to be confused by invasive growth. Tangential cutting can make some of the islands look as though they don't have a basal layer or basement membrane, but you have to remember this is like a 3D lesion which has been cut into 4 to 5 micrometer thick section. So you will see this variation. So a good thing to do is to stay at low power and assess the overall architecture. The overall architecture will again show very well regimented, similar thickness, trabecular growth. So wherever you see, you'll see mostly similar thickness of the trabeculae. Like I said before, tangentially cut lesions can have some kind of more thick areas, but overall, the theme is similar thickness of trabecular growth. You can see some budding of the basal layer. Sometimes the overlying urothelium is completely denuded. Other times you will see normal urothelial lining on top. Other times you will see some obtunded urothelial lining, and sometimes you'll see a more prominent overlying urothelial lining. Nevertheless, they are all carry their basal layer along with them and the basement membrane, making them into a inverted growth, not invasive. Having said that, there are variation in the themes. Like I pointed out in papilloma, the umbrella cells can have you can have a lot of atypia. And similarly, and in an inverted papilloma, you can see these very atypical nuclei sometimes. Um, Thankfully, they're not seen that often, but stay at low power and put them in the context of where you see them. If you see them more often in the intermediate layer and you're consistently seeing atypia, then you have to take a pause and rethink your diagnosis. Some lesions can have cystic spaces, and we will go over the differential diagnosis, how this differential diagnosis is different from other cystic lesions. Squamous differentiation has been described in inverted papillomas. So if you keep in mind that squamous differentiation is described, cystic changes have been described, and such kind of umbrella cell-like cells can look very atypical, then you will be able to put these findings in the context of the entire lesion. Now, here is a very nice example where the urothelium is a little bit thickened, and there is budding going on from the base of the urothelium. And here you can see that in between these papillae, there's swirling of the cells or spindly cells. This is something that that has been well described in inverted urothelial papillomas. So this is not an atypical finding. You can see a lot of swirling. So keep these 4 images in mind. Now, what about exophytic component? Well, a small amount of exophytic component is acceptable according to the WHO classification, but it has to be minimal. However, according to AFIP, true inverted papilloma should not have any exophytic lesion. In my practice, I do accept a bit of exophytic growth as long as it is very limited and the urothelial lining looks almost like a exophytic papilloma, normal looking lining. What are the differential diagnoses of this kind of exophytic growth? You have to make sure that are these really true papillae or part of the endophytic growth that has, kind of peeled off as a result of histology preparation or broken apart. You have to make sure if you start to see true papillae that there is no history of urothelial carcinoma. Then you have to kind of back off. And also remember to submit the entire tumor. Because if you're seeing true papillae, you need to examine all the exophytic growth in order to confidently make this diagnosis. What about molecular differences between inverted urothelial papilloma and exophytic normal papillary papilloma? So the inverted urothelial papilloma has a predominant pathway that it takes, which is HRAS. So predominantly it shows HRAS mutation, whereas the usual urothelial papilloma or exophytic papilloma shows mostly KRAS, but can have a combination of HRAS and KRAS mutations. And then there are multiple mutations that are overlapping between the two, but these are the 2 main differences between the 2 entities. And this was recently published in the Journal of Pathology by the Memorial Sloan Kettering Group. So in order to make confidently make a diagnosis of inverted urothelial papilloma, you have to follow strict criteria. One of the things that I did not have an example to really illustrate is that a well-oriented and well-cut lesion will show a sharp delineation of the inverted growth from its base. So that is one of the very giveaway kind of important criteria that you can use. Secondly, the endophytic growth is limited to the lamina propria. The cords and trabeculae have a bland cytology. The trabeculae have a very regimented growth pattern, pretty much all the same size. And if there is overlying urothelium, it's normal looking urothelium or very limited papillary growth with lined by normal looking urothelium. Just be very cautious if there is a previous history of treatment for urothelial carcinoma or even previous resection for urothelial carcinoma, exuberant exophytic growth, cytologic atypia with confluent large nests that are fused. We will go over this in the subsequent slides. And irregular intersections between the base and the stroma. This is the point that I was trying to raise, that the sharp interaction between the base of the lesion and the lamina propria should exist in a well-cut lesion. So what about their behavior? Majority of these are indolent tumors, and if incompletely removed, they may recur at the site. And these are four large series of described by various authors, and a total of almost 200 cases, where majority of them recur. However, the progression rate was not quoted as 0. And this progression rate ranges from 2% all the way to 8%, and some of it may be just a variation in histology of these tumors. So what are the benign growths in the lamina propria that can be mistaken for or try to mimic inverted urothelial papilloma? So majority of us can easily recognize cystitis cystica and cystitis cystica glandularis, but sometimes these can be really exuberant and mimic cystic spaces in an inverted papilloma. But here is a side-by-side comparison where you can see, if you keep to the definition of well-formed trabeculae, you don't see those in exuberant cystitis cystica or von Brun's nest. So again, we come back to the basics of the definition, that what is the basic growth pattern of these lesions. Like we mentioned before, inverted papilloma versus inverted pun lump. Inverted papilloma will have thinner trabeculae because these are normal urothelium that is growing in an inverted pattern, whereas we defined papillary urothelial neoplasia as having hyperplastic urothelium. And so therefore, the inverted pun lump will also have hyperplastic looking inverted growth pattern. And because it is hyperplastic, it'll look broader more often compared to the inverted papilloma. But you have to pay attention to the nuclei, and there should be minimal nuclear atypia, yet a very regimented growth pattern of the nuclei. Now, I would say making a differential diagnosis of pun lump and low grade itself in practice is really hard. So making the difference between inverted pun lump versus inverted low grade urothelial carcinoma is equally hard. The good thing is, majority of the low grade papillary urothelial carcinoma with inverted pattern of growth will have a well-formed exophytic component. Similarly in inverted papilloma as well. And so that's one point to contrast with inverted papilloma. So inverted pun lump and inverted low grade will have an exophytic component in majority of your cases. So here is an example where you can see a nice exophytic component of papillary urothelial carcinoma, and you can see various size and shapes of these inverted growth pattern pushing into the lamina propria below. And these are really complex papillae. They are fused, they are variously cut here. However, sometimes when there is a cystoscopic resection post-treatment, this exophytic portion may be totally obtended or removed, and you might have just mostly endophytic lesion, or also depends on how the lesion was cut. If this is put face down during embedding, you might just have a very prominent endophytic or inverted growth pattern. The way to make sure that you are not missing a carcinoma is look at the expansile growth of these inverted nests. Even though you can see some hint of basal layer here, these are really expansile growths into the lamina propria. And then you'll easily see cytologic atypia. You might see mitosis at various layers, and then from there, the diagnosis becomes easier. Sometimes you can see a good transition from what you may will agree looks like a inverted papilloma to a more broader papillae. And this is such an example. We have this example in the GUPS path presenter slides. So if you want to drive it yourself, you can take a look. And here you can see the transition from very thin papillae to larger and larger until they become very large and confluent and fusing papillae, bringing to mind the differential of low-grade papillary urothelial carcinoma. And indeed, this lesion elsewhere had exophytic papillary lesion, and also this patient had a history of urothelial carcinoma in the past. Another mimic of inverted, important thing to remember is large nested variant of urothelial carcinoma. These nuclei can be really, really bland, but these are really aggressive lesions, and they mimic the inverted growth pattern. But you can see here this growth is sitting all the way into in the muscularis propria. And here's another one that's going right through the bladder wall. So these are another mimics not to be missed. A small nested pattern is another entity that can be often seen in the lamina propria and look very, very bland. But remember, if it is going beyond the lamina propria, you have to be really careful. And this much of an expansile lamina propria invasion is very consistent with this aggressive entity of small nested pattern of urothelial carcinoma. Amongst the benign entities in the lamina propria, you can see nephrogenic adenoma. The nephrogenic adenoma can have a tubular pattern, which can mimic the tubular pattern of urothelial carcinoma. So you have to be very careful not to mix one or the other. Similarly, some of the nested pattern can mimic some of the benign growths like cystitis cystica, so shown here. And sometimes malignant entities may show some tendency towards looking trabecular, but you can easily recognize that as different, and you can recognize the invasive pattern with the reaction in the background, the variation in size and shape of these growths into the lamina propria. So this is an example of nested variants with cords and of urothelial carcinoma with cord and tubule formation, as opposed to nephrogenic adenoma in the slide previous. So with that, I will come to the summary of my lecture. So what we learned today is that the exophytic entities recognized by the WHO for papillary lesion, including papilloma, inverted pun lump, inverted low grade, and inverted high grade. Each of these have their inverted growth pattern. So one needs to recognize that inverted growth pattern is not only seen in inverted papilloma, but in malignant entities as well. We also went over some innocuous looking aggressive growth, which is large nested variant, for example, shown here, that should not be confused by, especially in areas like this, should not be confused by with a nested pattern of growth. We went over some of the benign entities that can involve lamina propria, for example, Von Brun's nest, tubular component of nephrogenic adenoma. Sometimes the nephrogenic adenoma can be really, really dense, but if you keep an eye out to look for these hobnail cells and a hint of pink basement membrane, you'll quickly recognize, no matter how dense, that this is a nephrogenic adenoma, and will not confuse it with the nested pattern or subtype of urothelial carcinoma. So in summary, we have to remember to recognize benign entities in the lamina propria, including Von Brun's nest, nephrogenic adenoma, and not confuse them with carcinoma. And amongst the inverted growth patterns, we have to learn to recognize the indolent behavior of inverted papilloma versus more aggressive behavior of pun lump and aggressive behavior or recurrent nature of low-grade and high-grade papillary urothelial carcinomas. With that, I'll end this lecture. These are all my references that I used, and thank you very much for your attention.
Thank you very much, Priti, for this very lucid presentation. You certainly made the topic look quite easy. So I'm pretty sure that the viewers will really enjoy this presentation. So friends, please make sure you like the video and share with your colleagues. And I think spread the word about this very good presentation. So with that, I thank you for your attention. And I will stop the recording.